Welcome, dear friends, to our session today. Today's session is case discussion, our case-based series, and this is the 18th case we are discussing. So today we have a case from Department of Medicine, All India Institute of Medical Sciences. So also they had done one case that was on fluids and electrolytes, which was very warmly received by all of you, and you have all seen that and participated in that. We thank Dr. AIIMS sir, who's Associate Professor, All India Institute of Medical Sciences, Department of Medicine, for moderating this and making this possible. The earlier one also, he only had moderated. Thank you so much, sir. Then we thank Dr. Kunal Sharma, sir is Senior Resident, Department of Medicine, All India Institute of Medical Sciences, and he's made a very lovely presentation. Thank you so much, Kunal. And joining us will be Dr. Ved Prakash Meena. The sir is Associate Professor, Department of Medicine, All India Institute of Medical Sciences. Thank you, sir, for sparing your time. And this session is going live on YouTube. So last two sessions also have gone live on YouTube. So apart from a Zoom link, you can watch on YouTube. Future webinars will also be conducted on YouTube as well as Zoom. So that was a little bit of information I wanted to give to all those who may not know. So with that, I hand it over to you, Dr. Kunal. Please start the proceedings.
Shall I start, sir? Is my screen visible?
Please.
Good afternoon, everyone. I'll be presenting a case of chronic obstructive pulmonary disease presenting with dyspnea. I'd like to thank my preceptors, Dr. AIIMS sir and Dr. Ved Prakash sir, for guiding me on the same. And I'd also like to thank Dr. Tapesh sir for giving me the opportunity to present the case and the discussion on COPD. So moving on, our case was a 56-year-old male who is a dairy owner from Delhi. And is an active smoker of around smoke with a smoking index of more than 800. Has also type 2 diabetic on OHS at home. And he has a history of, he had a past history of pulmonary tuberculosis twice, 2012 and 2016. Both times he had taken a treatment with anti-tubercular therapy for around 6 months. And he had improved in symptoms. Although he was on home oxygen therapy with 2 to 3 liters per minute, which he was requiring around 8 to 9 hours a day. And his baseline function status was of MMRC 2/3. And he was able to carry out his daily activities of daily living, and that was his functional status. So this gentleman presented to us in emergency with chief complaints of fever for 8 days, cough with expectoration for the last 8 days, and worsening breathlessness for the last 5 days. There was no other history of chest pain, palpitations, edema, loss of consciousness, hemoptysis, dysuria, burning micturition, seizure, bleeding, or jaundice. So keeping in mind, the predominant symptoms are respiratory. So we had differentials of lower respiratory tract infection in our mind, presenting with an acute respiratory failure. Second differential being an acute exacerbation of chronic obstructive pulmonary disease, and a lower lying differential of pulmonary embolism. Further on, the examination.
One sec, Dr. Kunal, one sec. Just go back. Dr. Meena, sir. The next slide. Dr. Meena, sir, you'd like to tell us when you call it an exacerbation of COPD?
Yes, exacerbation of COPD is when patient symptoms have increased apart from his usual states, and there is no evidence of infection. It's due to any airway causes.
Okay. So there is worsening of his usual cough, dyspnea, and expectoration, because normally also these patients have, when worsening in this would mean there's an exacerbation.
Yes.
So, and this Dr. Kunal, LRTI means what? Does it mean pneumonia, or what does it connote?
So it means a lower respiratory tract infection, pneumonia, given the mind the patient has a history of fever with increased cough and expectoration.
Does it mean only pneumonia, or it can mean something else also? This is actually not a specific term, LRTI. It is not mentioned, when you look up the books of medicine and chest, LRTI is not a word they use normally. So what is the lower respiratory tract? It is below the larynx.
Below the larynx,
yeah.
vocal cords.
So it can also mean bronchitis. LRTI would refer to either tracheobronchitis or pneumonia, or both.
Yes, sir.
So, but it is not a very specific term. One should actually either write pneumonia or tracheobronchitis or bronchitis. Huh?
Yes, sir. Yes, sir. I agree.
Carry on. Next slide, carry on.
So on examination, he was found to have be drowsy, confused, and not oriented to person and place, and blood pressure of lower side of around 92 by 64. He had tachycardia with a low volume regular pulse of around 124 minute, tachypnea of 30 per minute, and then a saturation on pulse oximetry of 70% on room air, increasing to about 92% on 10 liters by face mask. Rest of the general physical examination, as per, there was no pallor, icterus, clubbing, cyanosis. JVP would not be appreciated. The respiratory system examination revealed decreased air entry bilaterally with presence of bilateral V's. The cardiovascular examination was normal. The weight was around 60 to 65 and height was 5 feet 6 inches.
So, Dr. Kunal, why do you think he's confused?
Sir, the possibilities in this patient which can explain the confused state could be either hypoxemia, it could be because of the infection or underlying sepsis. It could also be because of acute, if the patient is having, given the history of COPD presenting with and having features of V's, could also mean a patient might be also having hypercapnia, leading to a persistent state of confusion. It could also be, yes, sir.
Yeah, anything else?
Sir, being also keeping in mind that the patient is a diabetic, so it could may also be because of hypoglycemia.
Hypo or hyper?
Sir, it can be either, sir. Either hypo may be patient can be confused, sir, and the sympathetic response can be explained by hypo as well as hyper.
So if there is hypoglycemia causing drowsiness and confusion, I think it would be quite bad. So that would be likely. It's possible, but that is not. I don't think that is really the picture here, because then there will be, sympathetic stimulation and BP would be higher. That kind of a thing will be there. Because sympathetic stimulation with the diabetic hypoglycemia, and
Yes,
if you have hyperglycemia, then it would be like a hyperosmotic coma, right? Just plain hyperglycemia would not cause drowsiness.
No,
They're talking about decay or hyperosmolar coma.
yes, sir.
So there you would get some more history, I think. But okay, I agree. Maybe there is sugar disturbance also. The other thing is there could be other factors also, like a sodium change or a urea change, also metabolic factors.
Metabolic factors.
Yeah. Okay. Now looking at the V's, why do you get V's actually in COPD patient or any patient? What is the cause of V's?
So in cause of
V's. Yeah. Why do you get V's?
Sir, it could be because of the narrowing of the airways. So again, it could be a polyphonic wheeze or which implies a diffuse process where there is a all spasm of all the smaller airways, leading to a decreased when the air is trying to move out, it will produce a musical sound. It could be a monophonic wheeze when there is a fixed mass or an obstruction in the particular airway and leading to a wheeze, presence of a wheeze during when the air escapes only in that particular region of the lung. So it could be in a COPD patient. It is because of there is a loss of elastic fibers.
No, that is okay. I understand. Whenever wheeze is seen wherever there is obstruction, right?
Obstruction.
So the obstruction actually leads to turbulence, and turbulence sends the bronchi into some kind of harmonic oscillation. That is the actual cause of the sound. Rest of whatever you said is fine. No problem with that. That's absolutely correct. But the actual cause of wheeze is turbulence. Crepitations occur because of, there's when the air passes through these fluid droplets, mucus and all, you get some crepitations or opening up of collapsed alveoli.
Collapsed alveoli.
So V's is due to turbulence, because this resistance is turbulence. So the bronchial walls are set into some kind of a harmonic oscillation. That is what they say why you get V's. Now the other thing is, you have seen many patients of COPD, right? So this saturation of 70 going to 92 with just 10 liters of face mask. Okay, this will not occur with a patient of ARDS generally, right? So
no, sir.
what does this mean actually? So patient of 70% saturation going on to 92 with only 10 liters of face mask. Does this mean anything in terms of physiology of respiratory disturbances?
Sir, it might be there's some amount of VQ mismatch happening, and it's not absolute shunt physiology of an ARDS.
Excellent. Excellent. So this is a feature of COPD, that they don't have shunting. And with minimal oxygen, they develop, normal saturation. So many times I have seen, I don't know whether you have seen, they come with saturation of 70-75%, and you give only 4-5 liters of oxygen and saturation jumps up %. This is a feature of COPD patients, and that is one of the reasons is because in fact, the main reason is shunting is minimal, less than 5% in COPD patients.
Exactly.
COPD patient requires more than 40 to 50% oxygen. That means some other pathology is occurring also. It is not just exacerbation, like a pneumonia or embolism or pulmonary edema, something else is also going on. Huh?
Definitely.
Carry on.
Just a small comment.
Yeah.
Takesh, would you agree with me when I say that if the patient is requiring 10 liters of oxygen by face mask, then the FI to delivered would be at least 60%, around 60%. So in that case, probably this FI2 is not that low to let us think about VQ mismatch. I would, rather be thinking about a shunt physiology. So, here my opinion would differ.
So, Dr. Ramesh, what I know is that with the face mask maximum is 40% FiO2, and that is with 50 liters, full flow, 40 maximum. Below that is very variable, depends on what the respiratory rate is, what the tidal volume is. So I assume that this is 30% FiO2, the 10 liters, but it maximum would be 40%. That is 60% with just a face mask would be very difficult.
Okay, fine.
Carry on.
So an arterial blood gas was obtained at the emergency department, and it showed a pH of 7.27 with a carbon dioxide partial pressure of 65 and a bicarbonate of 29, lactate of 1.9, and a partial pressure of oxygen around 71 millimeters of mercury. Rest of the electrolytes at the point of care was more or less within normal limits, with sodium a little lower, about 131 in the ABG. The interpretation of this ABG was a respiratory, it's an acute respiratory acidosis, which is acute and chronic respiratory acidosis, partially compensated.
So why is the sodium low?
Sir, I'm not really sure, but it's an ABG
Dr.
value.
Sir, you like to say why the sodium is low, or Dr. Ramesh, sir?
Well, sodium may be low because of number of factors. One is, normally we see whether it is euvolemic, hypervolemic, or, hypovolemic. So it can be so that the patient, has been drowsy for some time. So the patient had not been taking much of oral intake. So, his oral intake might have been compromised. So that might have led to something which we call as the hypervolemic, hyponatremia. We are also suspecting an infection in this case. So in that background, it may be something where there is increased ADH leading to something like this SIDH syndrome. And finally, if the patient has a component of, say, heart failure or something, because that's very common in a patient who has been smoking for a long time. 800 smoking index is what Kunal said. So if there is a component of, say, a core pulmonary or a heart failure on the background of COPD, which is not clear at this juncture, so it might also be, hypervolemic hyponatremia. So at this juncture, it's very difficult to say what the hyponatremia may be. It may be due to a number of factors. That's what I think.
Yes, absolutely. So one of the primary reason would, like you said, would probably be the exacerbation of COPD, bronchitis exacerbation, COPD exacerbations, or bronchitis itself can lead to hyponatremia. So pneumonia is a classic cause. Pneumonia leading to SIDH into hyponatremia is a classic case. But even if there's no hyponatremia, just an episode of chronic acute bronchitis can lead to hyponatremia. So Kunal, would you like to interpret the APG? What formula have you applied here to say that there is partial compensation, or what have you done with the ABG here?
So, sir,
right.
So, sir, this is looking at the pH. It is towards an acidotic side, so it's an acidosis. And looking at the bicarb and the CO2, it is predominantly there's a high CO2 with a high bicarb, so it's going towards a respiratory acidosis. And to see whether it is adequately compensated or not, so there, for every 10 assuming it's a chronic respiratory acidosis, for every 10-degree rise in CO2, there should be around 4 units change in the bicarb. So there is around 25 rise in PCO2 from a normal 40. So I would be expecting a bicarb of around 31 or around 33 or 34. but the bicarb is towards the lower side, indicating this has gone from a rather than from chronic acute respiratory acidosis, it has been only partially compensated acute respiratory acidosis on a background of chronic respiratory acidosis.
So the expected bicarb mode, right?
Expected bicarb would be more, sir.
So that means the entire process is not chronic. There's something acute is also going on, right?
There's some acute process which is going on a background of chronic process. So
yeah, so acute is one of bicarb for every 10 of PCO2.
Yes.
So it becomes difficult actually to exactly say what it is. There would be baseline PCO2 rise also, right? He's a chronic.
Yes, sir. He's a chronic CO2.
Maybe PCO2 is 45, 50, something like that. We do not know. It's very difficult to say. And now it's been going on for 6-7 days. So there's a chronic process. You know, the chronic process, the chronic compensation starts anywhere after 2 days, 2 to 5 days. There's no
yes,
time.
sir.
And there's an acute process also going on. So it's very difficult to say, but like you have rightly said, it is partially compensated respiratory acidosis.
Yes, sir. It is difficult to comment whether acute or how chronic before without a baseline ABG, sir.
Yes, it is very difficult to estimate. That's what I was trying to say. What is the baseline PCO2, the ABG?
Yes, sir.
Get a rough idea. And the other formula is that for chronic respiratory acidosis, the pH changes 0.03 for every 10 of PCO2. And for acute, it is 0.08 for every 10 of PCO2. That also helps in trying to evaluate what is the baseline PCO2, because the baseline PCO2 helps in your weaning. You try to aim for a baseline PCO2.
Exactly, sir.
Yeah, carry
on. So a baseline point of care ultrasound was done, which showed Schritt sign and presence of air bronchograms in the right anterior chest wall and in the anterior lung zones, as well as a X-ray which was subsequently obtained also showed a presence of a dense consolidation with a opacity in the right upper zones for the patient. So
just go back. Just go back. So, Dr. Animesh, sir, you like to tell the X-ray in detail for the audience, sir?
Right. So we can see, a chest X-ray. This is probably an AP view, and we can see, a white inhomogeneous opacity in the right upper zone, which is suggestive of a consolidative process which is happening. There appears to be, the heart shadow, the cardiac silhouette appears to be a little tubular. And I would like to, though I'm not able to count the exact, the intercostal and the ribs, but I think there is an element of hyperinflation also, as evidenced by the flattening of the right cupola more than the left cupola. So I feel that this is on the background of COPD. This patient is presenting with a consolidative process, which is probably a pneumonia affecting the right upper lobe.
And there is evidence of some calcification and fibrosis also, I think, residue of tuberculosis, some fibrotic strands and calcific spots.
Yes, the left upper zone shows some fibrotic opacity.
And sir, there's a rounded opacity in the right upper zone, which could be lung cancer possibility. I mean, do you think it is not clear? Right now, of course, it looks like consolidation, but it cannot be. I think you think it could be cancer also.
I mean, the clinical features does not suggest that, but sometimes it may be so that there's an hidden mass underneath. So I think we have to wait for the antibiotics to take effect, or we have to plan an advanced imaging to understand.
Absolutely. So the other thing I would like your comment on is the vertical line running along the left heart border. Is that because of rotation and fibrosis, or what? The left cardiac silhouette is kind of going slanting vertically upwards. Yeah, the left, this one, this down, go down. Kunal, go down. Yeah, this one, this is going like that. So there is some rotation also in the X-ray and fibrosis, probably because of that, it is getting distorted or what?
Probably it does not look like a collapse or something, but probably there's a rotated, because normally we would expect 1/3 of the cardiac shadow to be on the right side of the vertebra, which is not there. So either there might be a fibrotic process which is pulling the heart to the left side, or I'm not sure about the rotation part, because I'm not able to see the ribs, the medial ends of the clavicles with respect to the vertebrae. This is not appreciable in this X-ray. So, probably there might be a rotational.
No, the clavicle is positioned differently. There is rotation. If you look at the clavicle, the position of the anyway. So I think that is all there is in the X-ray. Like Sarah said, there is flattening of diaphragms, and there is a homogeneous opacity on the top. That is suggestive of consolidation. There's some calcifications, spots of calcification. There is some fibrotic stranding, and there might be some degree of rotation. So that is there in this X-ray, and let us move on then. Okay, Dr. Kunal, move on.
So based on these findings that we have got at the emergency department, a provisional diagnosis of a 56 male with active smoker with type 2 diabetes mellitus and post TB sequelae with presenting with an acute exacerbation of COPD with pneumonia and in acute respiratory failure was kept. And before we go on to discuss what happened to the patient afterwards, I'll just like to briefly discuss a few pathophysiological concepts behind COPD and exacerbation of COPD per se.
The one thing, before that, why are you saying there is post TB obstructive sequelae? Which obstructive sequelae?
After the episodes of pulmonary TB in 2012 and 2016, he was also he was also taking home bronchodilators, and he was having shortness of breath and episodes of wheezing, although no episodes of previous exacerbation or hospitalization. So there, apart from the smoking being contributory to the COPD, I think there is also a component of post-TB obstructive sequelae contributing to the obstructive pulmonary disease.
No. What obstructive sequelae do you get after tuberculosis?
Sir, it could be in the form of bronchiectasis.
But without documentation, you cannot say like that. You have to have a CT. Either there was a CT done earlier or a CT done now. You cannot assume it like that. He has COPD. He's been a smoker, so it is the dyspnea and the cough and expectoration did not start before he started smoking, right? It was after he has been a chronic smoker for many years.
He has been, sir.
So you cannot. That would be, fact. That would if anybody was appearing in the exam, that would be putting a foot in the mouth. You cannot say like that unless there were documentation of bronchiectasis. There's nothing on the X-ray also with whatever you can see. So without a CT, you cannot say. No, I don't think you can say. There is no evidence to say there is bronchiectasis. I mean, you can. There might be, but then you have to do a CT. He's had 2 episodes of tuberculosis, like possible, but and COPD itself is associated with bronchiectasis, right? So again, you cannot say whether this is because of tuberculosis, even if you get bronchiectasis.
So Dr. Tapesh, just a small comment regarding this. Nowadays, what is happening is that with tuberculosis, we are reporting a condition called TOPD, or tuberculous obstructive pulmonary disease. Previously, we used to think that smoking leads to COPD, but smoking has been proved as not only the only factor which can give rise to COPD. So nowadays, as risk factors, tuberculosis is also considered to be a risk factor for COPD. Well, as Kunal said, not only bronchiectasis, but tuberculosis can affect the small airways and the medium-sized airways as well. So, we see young persons, young male or young females, as many as 30 or 40 years after tuberculosis, they present with a typical history of obstructive airway disease. And when we do a spirometry, they show post-bronchodilator FEV1, FVC less than 0.7, so which qualifies for the diagnosis of COPD. So variably, this is called TOPD at times, or sometimes they are called post-tubercular obstructive airway disease, right? So now this condition is not that well known, but our department is actually involved with a little bit of research regarding this, and we are getting more and more we are understanding and appreciating more and more cases with post-tubercular obstructive airway disease. In this particular case, as Kunal was saying, that after 2012, when he had tuberculosis, there was a sudden worsening of his symptoms, cough, breathlessness. So he has been a smoker for some time, but after an infection like tuberculosis, if there is sudden worsening, and that worsening persists, so that is a strong ground for us to anticipate or expect that the patient might be having this post-tubercular obstructive airway disease. So it's a new concept. We are not exactly sure how it happens, etc., but we are warming ourselves to this concept.
No, but would it not be an early stage of bronchitis in this? Have you followed up these patients?
No, so these patients, some of these patients, they have bronchiectasis. Some of them do not have. Most of them, in fact, do not have bronchiectasis. They have, sorry. So on CT scans, what they have is mosaic attenuation. That is what they have. And as I said on PFT, they have typical FE1 FVC less than 0.7. So not all.
Okay, that's great then. You are reporting a new condition. Excellent. Many congratulations for your work on this. Excellent. So, Dr. Meena sir, acute respiratory failure is, you like to tell us type 1, type 2, and how many types are there, acute respiratory failure classes?
Am I audible?
Yeah. So, respiratory failure, type 1, type 2, and there are some other types also, if you would like to tell us.
Yes, sir. In type 1 respiratory failure, there is no CO2 retention. Only there is hypoxemia. Only oxygen saturation is low. What happens in type 2 respiratory failure is there is CO2 retention and hypercarbia. And then other type, I am not very sure. Dr. Anmesh, you can highlight that.
Normally we use type 1 and type 2, but type 3 sometimes perioperatively, I think they refer to type 3 respiratory failure. And type 4 is when there is a cardiac dysfunction involved in that. So I agree with you. Type 1 and type 2 is where what we see. Type 1, PO2 typically less than 60. Type 2, PCO2 is more than 50. But sometimes also we refer to type 3, type 4 as well as I think a mixed respiratory failure where you get both type 1 and type 2. But,
so yeah. Type 4 is also, sir, basically they are saying ki, because of the hypoperfusion of the respiratory muscles in a shock state. So
right. What I meant was cardiac failure.
No, exactly. No, absolutely, Dr. Animation. That is what it is. Hypoperfusion or cardiac cause, because the low cardiac output. The shock state is the classic state. The respiratory muscles are overworked and there's hyperperfusion, or even in conditions like thyrotoxic crisis, you get it where the muscles go into fatigue. Overwork of muscles is there and the muscles are not supplied adequately, even thyrotoxic crisis, and wherever there is a mismatch between the supply of oxygen to the respiratory muscle and the lungs are inherently normal. So that is type 4. And type 3 is post-operative. Absolutely. Carry on.
To discuss a few concepts behind pathophysiology of COPD. So classically, we are taught about the two phenotypes of chronic bronchitis as well as an emphysema. What happens in chronic bronchitis is a hyper secretion of mucus in the major airways with mucosal hyperinflammation. In high emphysema, there is loss of these elastic fibers which hold the alveoli or the small airways open because of the loss of elastin fibers. Although the distinction between the two is slowly fading, and what we used to previously being taught as a pink puffer and a blue bloater is slowly disappearing. So there are a lot of overlap between the two phenotypes. The first important concept in COPD is the concept of flow limitation. Again, this arises because of the fact that the elastic fibers are being degraded or lost over a period of time because of the inflammation and the smoking related inflammatory neutrophil elastase activity. So as the elastic fibers are lost, they lose their tethering effect on the smaller airways. This radial attachment, this is lost, and this because of this disruption, these smaller airways tend to collapse and tend to close. So what happens is ki when they close, as much as the person tries to increase their expiratory muscle activity or their driving pressure, they cannot increase their expiratory flow beyond a certain amount of beyond a certain limit of flow, and so the expiratory flow becomes capped out at a maximum limit. In a normal patient, the slope of inflation is perfectly fine, vertical, and the patient can achieve an expiratory flow up till Vmax. But in a COPD patient where the tethering effect is lost, there is a critical there's an airway collapse. And so during the expiration, the patient cannot expire beyond a certain flow, and this tends to plateau out. So what happens is after this expiratory flow limitation sets in, the time to expiration also goes down. And as the patient is not able to get out the air during the expiration, this leads to a phenomenon of air trapping or dynamic hyperinflation, which propagates the further filling of air with subsequent breaths in the alveoli, leading to an increased end expiratory lung volume. This end expiratory lung volume is further worsened during a period of exacerbation by an increased respiratory rate, increased tidal volume, and a decreased expiratory time. And this further leads to more air trapping and a vicious cycle of more dynamic hyperinflammation. So dynamic hyperinflation, again, as the alveolar walls are destroyed, the elastic recoil is lost. The expiratory flow limitation sets in. There is a delayed expiration, or there is a shortened time to complete expiration, leading to air trapping, leading to increase in the expiratory lung volume, and further setting up a physiology of autopeep or intrinsic peep, which is nothing but the positive pressure in the alveoli at the end of expiration because of the chronic air trapping. So what happens in an exacerbation? Again, this dynamic hyperinflammation, the patient's minute ventilation demands go up during an exacerbation. So the tidal volume, the patient will try to pull in more tidal volumes. The patient will, as the patient is not able to pull in, the patient will become more tachypnic. So minute ventilation goes up. To match this, there will be further decreased expiratory time to achieve this. So as a further the expiratory time is reduced, they will further compound the air trapping, and this will lead to more work of breathing and more patient ventilator asynchrony, and this will further amplify the expiratory flow limitation. So as the dynamic hyperinflation sets up a vicious cycle and leads to a phenomenon of autopeep, this has negative consequences in the form of both on the cardiac condition, on the respiratory muscles, as well as on the further worsening dyspnea. So to summarize this, in a COPD, the patient already is in a state of expiratory flow limitation with a dynamic hyperinflation. And as in when an acute exacerbation sets in, there is an increased ventilatory drive along with a tachypnea and a component of anxiety, which further puts the lungs at a state of mechanical disadvantage in the form of increased autopeep because of the expiratory lung volume and the air trapping. And the respiratory muscles, which are in a chronic state, the diaphragm is already flattened and working again in a stretched state. This further leads to dysfunction of those muscles. So they have to work against a higher pressure and a higher volume. And this leads to a further inspiratory muscle dysfunction. This leads to also a state of a poor gas exchange because of poor ventilation, and also has a tendency to impact on the cardiovascular status of the patient, as in the hyperinflation, as it worsens, it increases the intrathoracic pressure, decreases the RV of RV preload, and tends to increase the pulmonary artery resistance, and which further increases the RV afterload. So that can have a negative hemodynamic consequence in the form of hypotension and right ventricular dysfunction.
So just go back to that. Okay. So just to summarize what he has said, very nicely has put up the slides and try to explain the physiology, or rather the pathophysiology in COPD. So why is there obstruction? First of all, obstruction is not only in expiration, even in inspiration. We all talk about expiratory flow, but the obstruction is also in inspiration. Now, there are three reasons why there is obstruction to airflow. First, the airway is narrow. The airway is narrow because there is goblet cell and mucous cell hyperplasia, because there's fibrosis, because there's bronchospasm, and there is lots of some small airways. The disease is in the small airways mainly, unlike asthma, which is a large airway disease. So this is the first reason: the small airway is narrow, and there's loss of some small airways. So the same amount of air has to go through lesser number of small airways, so the resistance is increased. Okay. Second point is, the elastin fibers are destroyed. The lung parenchyma has elastin fibers which have pulled the bronchioles outwards. Okay, there's a radial traction outwards because of elasticity. These fibers get destroyed, so there's a tendency for the small airways to collapse. And the third reason is the elastic recoil. Again, these elastic fibers which are destroyed, the lung is elastic. So when it's inflated, it is tense, and when the expiration starts, it moves inwards, and this inward movement, the elastic recoil, is decreased in patients because the elastin fibers are destroyed. So again, there is a slowing of the expiratory flow. So these three reasons cause expiratory flow limitation. But one must also realize there's an inspiratory problem also. Work of breathing is increased because there's an inspiratory problem. And the consequences of hyperinflation is, one, that the diaphragm is put at a mechanical disadvantage. The diaphragm is pushed down because there's hyperinflation, and the chest wall expands. You have a barrel-shaped chest. So all this puts the musculature, especially the diaphragm, at a mechanical disadvantage. Apart from this, the patient has to generate greater amount of effort to breathe in, okay, because there is dynamic hyperinflation, the resting lung volume is increased. So you have to generate a greater effort. And third is, this leads to pneumothorax. There's a tendency for pneumothorax and bulle formation here. So this is in a nutshell what he has very nicely explained to you. Okay, doctor, anything you want to add, Dr. Nimesh, sir?
No, absolutely. It's fine. Absolutely.
Yeah, carry on.
So the another concept that I want to touch upon is the role of supplemental oxygen in a patient with COPD. So as Sir has rightly pointed out in the beginning, so patients of COPD usually do not have a shunt physiology going on, or a very minimal shunt physiology going on. So giving high flow oxygen, giving oxygen in these patients has been shown to be associated with higher mortality compared to a strategy of, let's say, a tailored conservative approach. So how much supplemental oxygen should be given in a COPD patient who is hypoxemic? And really, is there any role of this? So there were three theories put forward to explain why there is a increase in PCO2 after giving supplemental oxygen, whether supplemental oxygen is useful in COPD or not. So the first theory was taught to us in medical school was that O2 administration in COPD is dangerous. This is because apparently it increases the arterial oxygen tension in the alveolar, leading to a decreased blunting of the respiratory drive, leading to CO2 retention. But again, this was a misconception, as was proved in a study in 1980, where it was shown after giving patients supplementary oxygen, the minute ventilation initially decreases, as shown in the rep tracing, but it subsequently recovers within 5 to 10 minutes, and it almost reaches the normal state of minute ventilation. So that should not explain how the CO2 is getting retained. In the same patients, it was seen after giving supplemental oxygen, even though the minute ventilation is recovering, the PCO2 is not recovering, and the PCO2 keeps on rising. So hypoxic drive as a theorem cannot totally explain the rise in PCO2 in patients who are giving supplemental oxygen in COPD. So this led to searching for other factors or mechanisms at play. So a theory with the help of a Haldane effect was put forward. So as we know, a deoxygenated hemoglobin has a higher affinity for carbon dioxide. So in venous blood, a high amount of deoxygenated hemoglobin is formed. So what happens is when in the lungs, when a higher supplemental oxygen is given, this equation is shifted towards the right side. So the carbon dioxide, which is bound to the hemoglobin in the form of carbaminohemoglobin, dissociates and leads to an increase in PaCO2 in the blood at the alveolar end. But because the patient is having an obstructive physiology like a COPD, or because of airway resistance, or even in asthma, the CO2, which is increased at the circulation at the lung side, is not able to be cleared up. So this leads to a rise in PaCO2 in the circulation, and this explains around about of 25% of total PaCO2 rise with the use of supplemental oxygen in COPD. Another theory that was put forward, and which is the predominant theory for explaining the hypercapnia with oxygen supplementation, was the loss of VQ mismatch, loss of shunting, and for compounding of VQ mismatch with the abolishment of hypoxic pulmonary vasoconstriction. So what happens is, in a normal lung with a normal ventilation and perfusion, there is no hypoxic pulmonary vasoconstriction. As soon as there is a disruption in the alveolar ventilation, so the alveolar will have a lower oxygen tension, and the pulmonary circulation, to adapt to this hypoxemic state, will undergo vasoconstriction so that the blood is shunted towards better ventilated regions of the lung. And this ensures that the VQ mismatch doesn't worsen, and there is favorable gas exchange happening in the lung, and so as to provide an adequate amount of oxygen to the circulation. This hypoxic pulmonary vasoconstriction is a natural mechanism of the body to protect against shunting. As we give a higher alveolar oxygen through inspired supplemental oxygen in COPD, what happens is this alveolar, which is poorly ventilated, gets a higher oxygen tension. This higher oxygen abolishes this mechanism of hypoxic pulmonary vasoconstriction, leading to vasodilation. And as this alveolar segment is already poorly ventilated, this will have because of the disruption of pulmonary vasoconstriction, it will have further increase in blood supply, and this will worsen the shunting, and total overall it will worsen the VQ mismatch, leading to a CO2 retention because of the poor ventilator physiology, and also a poor shunting, leading to further worsened gas exchange. So it was seen that the hypoxic pulmonary vasoconstriction in a stable state maintains a counter-regulatory mechanism against shunting, and it improves the gas exchange. But whenever we give a supplemental oxygen in these patients, which is more than the required limit, it disrupts this protective mechanism. It worsens the VQ mismatch, and this contributes predominantly to the auto-induced hypercapnia in these COPD patients. So it is recommended that we give a titrated oxygen strategy to these patients, targeting somewhere around 88 to 92%, and to barely avoid hypoxemia, as well as also reduce the risk of oxygen-induced hypercapnia in these patients. So Dr.
Kunal, very nicely you explained again. So there are three reasons summarizing that. One, the hypoxic drive gets knocked off when there is hypoxia, the hypoxic drive is very strong, and if you have oxygen, the hypoxic drive is blocked off, so the patient starts hypoventilating, the PCO2 goes up. Second, there is hypoxemic pulmonary vasoconstriction protective going on. So this again is protective in the sense that it does not let PCO2 rise, and when you give oxygen, this protective hypoxic pulmonary vasoconstriction is released, which leads to a imbalance in the V by Q, leading to PCO2 retention. Third is the Haldane, which is very important. The Haldane effect, which we do not talk about, is actually probably the most important, some people say. So these three factors lead to a PCO2 rise on giving oxygen, but like we said, you have to give oxygen or the patient will get knocked off. So oxygen has keeping saturation around 90%. Carry on.
So coming back to the patient, so treatment along the lines of an acute exacerbation of COPD with pneumonia was instituted, and he was started on nebulization with bronchodilators. Systemic steroids were administered, magnesium sulfate 2 grams were given, and intravenous antibiotics, broad spectrum antibiotics were started. The patient was also given a 1 liter RL bolus, followed by 1 unit on flow, given the hypotension. Although pocus assessment of hemodynamics was not really clear. Patient was also, based on the increased RBS of around 208, patient was also given a start dose of correction, 4 units insulin was given. Regular insulin was given. Preliminary labs were awaited. The patient still was on 10 liters per minute face mask and was not showing any change in response. So what would be the next best step for this patient at this current setting?
So just go back, please, 1 second. Okay, so I think we have to discuss a little. So I think Dr. Animesh sir, please comment on the use of magnesium sulfate in COPD. Like asthma is well known, but your comments on use of magnesium sulfate in COPD.
Yes, so I mean, previously magnesium sulfate was used in asthmatic patients only. We used to use 1 or 2 doses of magnesium sulfate. But nowadays there has been some emerging evidence about the use of magnesium sulfate in COPD as well. We were just reviewing the topic yesterday, I think, where there was a systematic review where they had actually reported 3 cases recently published, and they have seen that use of magnesium sulfate of 2 grams single dose for acute exacerbation of COPD patient in the emergency, provided the patient has not responded to the initial bronchodilators, that led to decreased hospitalization. So magnesium sulfate 2 gram single dose can be used in acute exacerbation of COPD for those patients who have not responded to the initial bronchodilators. So this is one of the practice changing updates which have been included in up to date.
Right. Thank you, sir. So again, now coming back to you, Ali, sir, pulmonary infections being an area of expertise for you. So can you tell the audience about first the organisms that we see in COPD and what antibiotics should we give? And are organisms and flora different from the West in COPD?
So the question is directed towards me?
Yes. Again, for you, because I'm talking about infections here. So in COPD, is our flora different from the West, and what kind of antibiotics should be given?
Right. So that's a very important question. Actually, we don't have much idea about the flora in our country, honestly speaking. So much of our practice and data is based on what is seen in the Western literature. Now, pneumonia and COPD, they can be caused by the common organisms, pneumococcus, H. influenzae, etc. But in certain populations of COPD, I'm talking about Western literature mainly, it is seen that, which are these populations, mainly those having severe COPD, FEV1 very less than, say, 30% predicted, or who have had prolonged use of corticosteroids, or who have had a pseudomonas grown in the last 1 month, or use of a broad spectrum antibiotics within the last 3 months. So, or who have a bronchiectasis documented on imaging. So, these 4 or 5 factors, this might lead us to believe that Pseudomonas may be a primary driver or primary, maybe a potential organism in this population. So in these individuals, especially if they have pneumonia on X-ray, we would want to cover with piperacillin tazobactam or any other anti-Pseudomonal drugs. Beside the common organism Pseudomonas, MRSA is also seen in some population as per as per reported in Western literature. One important thing is when we are choosing the antibiotic, sometimes it's also helpful to ask the patient or the patient's attendants about the antibiotic which he has used, because commonly it so happens that by the time the patient comes to us, say a tertiary care hospital, he has already received, say, a third generation cephalosporin and has not responded. So in that case also, continuing the same antibiotic, probably if it is an infective process which has not responded, does not make any sense. So in that case also, we might choose to upgrade the antibiotic to, say, piperacillin tazobactam, ceftazidime, or so on. So I think these are some of the common paradigms related to the use of antibiotics in COPD patients.
Okay, thank you, sir. So generally, from what I can gather is the Western guidelines or the Western flora is what we also see, and there's lack of proper data from our setting. Okay. So the other thing is, sir, should all patients of COPD exacerbation, this patient has a pneumonia, fair enough, but sometimes there's no pneumonia, there's just an exacerbation. And COPD exacerbation, 1/3 is non-infectious, 1/3 is viral, 1/3 is bacterial. That is what the data says. So should all patients get antibiotics, or which patients get antibiotics in COPD exacerbation without pneumonia?
Sure. So not all patients, they would require antibiotics. So commonly we give antibiotics to those patients who have two of the three features of increased shortness of breath, increased cough volume or viscosity, increased sputum purulence. So any two of these three, they are increased, we would give antibiotics, or the patient requires mechanical ventilation. Even if these three features are not there, then those would be upfront indications for giving antibiotics.
So if the patient is not too bad, then you can withhold antibiotics. That is the other way of looking at it.
Mild exacerbation, not infective. It doesn't look like.
Yeah. So clinical judgment has to be made, and severe COPD exacerbations have to be given antibiotics. And probably you can also use Procal or something like Procal or CRP. If it is elevated, then one would like to give antibiotics. The normal Procal or CRP would not rule out infectious process. But if it is elevated, then you would go for antibiotics, or if the TLC is increased. So that is the take-home message here is, one thing one should realize is that not all exacerbations are infectious. 1/3 is non-infectious because of whatever reasons are not clear. There's an exacerbation, maybe because of pollution, exposure to something. The 1/3 is viral, 1/3 is bacterial. And if required, the patient is sick, going onto the ventilator, or severe acidosis, then you have to give antibiotics. Okay. Carry on, Dr. Kunal.
So, sir, so at this point of time, there was a discussion whether the patient should be upgraded with respect to the oxygen delivery device. So he's on face mask, still per minute, he's tachypneic, still in distress, having still around borderline blood pressures, but MAP is being maintained, pulse rate of 126 of tachycardia. ABG picture was same. ABG picture was showing respiratory acidosis. So, and this was on 10 liters face mask. So whether we should go on to an hfnc, should we proceed directly to an invasive mechanical ventilation, or should we try an NIV? So being a AECOPD patient, so obviously the first line standard of care, what we've been taught is to start with NIV. So before we discuss what happened with this patient, I'll just touch on a brief aspects of NIV in a AECOPD patient. So physiologically, how non-invasive positive pressure ventilation helps is it unloads the works just on the respiratory muscles. As we know, the diaphragmatic muscles and the respiratory muscles are already overworking against the odds. So it helps unload that. So it helps in decreasing fatigue and respiratory rate, contributing to an decreased work of breathing. It can improve gas exchange. Overall, it also with unloading, it also decreases the dynamic hyperinflation, allowing more time to expire with the appropriate settings, and so on. Overall, decreasing the partial pressure, decreasing the CO2. Further on, it can also decrease the need for endotracheal intubation and invasive mechanical ventilation, and hence so forth, the complications related to the same. So NIV is quite an effective instrumental bridge for administering therapies like steroids, bronchodilators, and antibiotics, and by time, so the patient can either stabilize and then see whether the patient improves or doesn't improve. So major societies have recommended NIV as a first line standard of care in patients with COPD with acute respiratory failure. This has come mainly from evidence showing decreased mortality, need for lower need for mechanical ventilation, decreased hospital stay, and reduced pulmonary complications. And level 1 evidence strongly favors the use of NIV, even recommends the use of NIV in 3 classical conditions, including AECOPD, and also its use in to facilitate weaning, or as a tool for helping in extubation in COPD patients, also in states of acute cardiogenic pulmonary edema. So the indications for NIV in COPD include, again, a patient who has come with acute exacerbation with respiratory acidosis and who is retaining CO2 and having a high work of breathing, including a respiratory rate of more than 24. And for these patients, we typically prefer a bilevel NIV and positive pressure ventilation rather than a continuous positive pressure ventilation. We should know the absolute contraindications to NIV and when to decide not to to directly upgrade to an invasive form of ventilation.
So don't read that. That will take too much. Just go to that contraindications.
So an absolute contraindication include.
Just read the absolute.
So an impending respiratory or a cardiac arrest, and a trauma or an injury or a burns to the upper facial airway or a fixed upper airway obstruction.
So
these are some of the absolute contraindications.
Pneumothorax is also absolute contraindication, and severe hypoxemia. Yeah.
Severe hypoxemic respiratory failure. Yes, sir. So a few interfaces.
Next slide.
So initiating NIV, of course, if the patient is competent. So once the patient is on NIV, the goal is to optimize the patient comfort and decrease the work of breathing. So we try to target a tidal volume around 6 to 8 ml per kg, and keeping in mind the respiratory rate around less than 35, and avoiding any dyspnea or distress for the patient. Try to titrate FiO2 again to keep an SpO2 of 88 to 92, and very important to ensure that the mask interface is appropriate and there is no leak. So again, to counteract the major pathophysiology of COPD, which is the dynamic hyperinflammation, we tend to reduce the inspiratory time and increase the expiratory time. And this we do by increasing the flow threshold of cycling sensitivity. And this can also be done by decreasing the tidal volume that the patient is getting per insufflation time, which is done by decreasing the pressure support.
Dr. Kunal, just a couple of things here. First of all, respiratory rate probably should be less than 25 to 35 would be to like to get it down to less than 25. And how would you initiate it now here? Patient is there with COPD. How would you practically set your pressure support?
So PEEP, I would like to set, I would start
pressure
with
support. How much you like to give pressure support?
Sir, I would start in an incremental strategy. So I would start with a pressure support of, let's say, 6 or 8 8 centimeter of water. And I'll again keep it on the bedside on the patient's face and see how much tidal volume is generating, how much dyspnea is it reducing or is it not reducing, and is there any improvement in the work of breathing. If it isn't showing any chances of any signs of improved work of breathing, so I'll increase that pressure support further by 2 in increments of 2 till I can achieve a good appreciable respiratory rate and a tidal volume of 6 to 8.
Yeah, tidal volume has to be targeted. How will you set PEEP?
So sir, PEEP, I would in COPD patients
yes.
with, classically with a type 2 with a hypercapnic respiratory failure, I would try to keep
this patient,
sir, around 4 to 5 lower, to try to keep it on the lower side, and to avoid basically further compounding the autopeep. So with a non-invasive positive pressure ventilation, it is very difficult to measure the exact P-plat or the exact amount of diamond in the hyperinflation. So titrating PEEP is a little bit difficult. I would like to keep it
can you do it? Can you titrate it? Are there any methods?
Sir, there are ways like using an esophageal manometry or
no. Simple bedside. Like you have rightly said, you cannot measure intrinsic PEEP or you cannot measure P-plat, but that is possible only with a hold on the. But are there any methods described to set PEEP? Okay, so there are a couple of methods described to set PEEP. You start from 0 with increments of 1. And the way you titrate it is, there are 2-3 methods. One, you ask for the patient comfort levels. Simple. Second, you look at the sternocleidomastoid. The patient will be in respiratory distress, and the sternocleidomastoid will be acting over time. So as the activity, you start increasing the PEEP and look at the activity of sternocleidomastoids, they will start decreasing, right? So when you reach the optimum point, that is the optimum external PEEP. Okay. You got it now. The respiratory distress is decreasing.
Yes, sir.
Muscle activity will go down. Third way is you look at the number of breaths. That is the ineffective triggers.
Ineffective triggers.
Triggers occur because of dynamic hyperinflation or autopeep, whatever you want to call it. Okay. So you start increasing the peep and you look at the triggering. As the triggering decreases, the mistriggering decreases. That means your extrinsic peep is improving. That is the right value you are achieving. So you look at the improvement in the mistriggering, and as you get the optimum level, you stop there. So these are the three ways of setting extrinsic peep on NIV. Okay. And the other thing is on NIV, always try to set leak compensation. Leak compensation is a general concept, and if it allows, most of the ventilators allow, leak compensation helps in synchrony.
Yes, sir. Thank you, sir. So this was the expiratory flow cycling threshold, what we try to set a little bit higher in a patient with an obstructive physiology. So to allow a higher, longer time for expiration and a shorter time for inspiration, so that it helps in alleviating the dynamic hyperinflammation and reduces the work of breathing and reduces some of that air trapping and reduce that autopeep.
So in a sense, this actually means that you cycle off early, inspiratory time.
Early.
So you get a prolonged expiration.
Prolonged expiration.
60% or something is appropriate for COPD patients. That is cycling. So early cycling shortens the inspiration and increases the expiration. That is achieved. Carry on.
A few drawbacks which with an IV associated, as you all know, claustrophobia, skin irritation, pressure ulcers. So very important to know how to monitor and how to predict failure on non-invasive positive pressure ventilation. So there are a few parameters and indices that have been suggested. The first would be, I would like to discuss a prediction tool which was given by Conflin et al. So at admission, GCS of less than 11 and Apache score of more than 29 and respiratory rate of more than 30 with a pH on ABG of less than 7.25 at admission predicted about 70% risk of NIV failure. And at the same parameters being kept in mind, at the 2 hours end of NIV, predict if the scores are being fulfilled, it predicted the failure with a 90% success, 90% failure rates. And this was with a high specificity. Apart from that, there are a few monitoring tools that are very important while the patient is on NIV. So again, we like to keep the tidal volume in check, the respiratory rate, and further worsening increase respiratory rate portends poor tolerance to NIV or a failure of NIV. And again, as a tidal volume, try to keep it between 6 to 8, and also few scores like the BAP 65 score has been suggested as a tool for monitoring for NIV failure. So what happens in this score was validated.
Next slide.
So our patient was started on non-invasive positive pressure ventilation. At the end of 15 minutes, he was still tachypnic at the pressures on a pressure support of 10/5 and pulse rate of 136 per minute. He was agitated and in distress. So the pressure supports were further increased to 14 in stepwise increments, and expiratory flow cycling was also increased. The status at 30 minutes failed to improve, showing marked tachypnia and further worsening in pulse rate with a hypotension, although MAP was still around 60-64. And the patient was becoming a little bit
worsening. Sensorium is worsening.
So the sensorium worsening at this point of time, there can be two causes, sir. It can be most likely an hypercapnic.
Is the sensorium worsening?
Sir, yes.
Huh? So what is the likely cause?
Sir, could be that the hypercapnic part is acting up, and it could be a acute CO2, acute and chronic CO2 retention leading to the worsening of sensorium. So hypercapnia.
So the saturation is 92%. Saturation is 92, so there is no hypoxia. Hypoxia also can lead to worsening of sensorium. So there is likely hypercapnia, worsening of hypercapnia. So why should hypercapnia worsen here?
Sir, the one possibility could be that the respiratory rate being so high and patient being on NIV, the patient is still having a tremendous amount of hyperinflation, which is not getting corrected, and this further leading to a vicious cycle of for increasing autopeep and air trapping, leading to a worsening CO2 retention and leading to hypercapnia. There could be a bronchospasm, sir, which can be also leading to worsening CO2 retention.
Go to the next slide. Let us see if anything else is there.
So at this point, an VBG was done, which showed a pH of around 7.08, which was had further significantly declined from the previous ABG. and a BICA of 38 and a worsening lactate, and a PO2 of 46, which is on a VBG.
So all the factors you have said are probably right, but in terms of physiology, what is happening that the PCO2 has gone up so much? In just one word.
Dynamic. Sorry, sir, I did not catch that last question.
So why has you have said so many reasons for PCO2 going up and the PCO2 has gone up, right? That is why it's becoming drowsy and all that, worsening sensorium. So why has the PCO2 actually gone up in terms of physiology? You talk about hypercapnia, and hypercapnia has physiological reasons. So the answer is the minute ventilation has decreased. Whatever factors are occurring has led to a decrease in minute ventilation. Bronchospasm, autopeep, asynchrony, missed triggers, everything is leading to a very low
decrease minute ventilation.
That is why the PCO2 is going up and why is becoming obtunded. So that is happening here. Now about the ABG here. You see the ABG PCO HCO3 has gone up to 38. Earlier it was 20. So what is happening here is this has happened in 5-10 minutes only. Over how much time has this happened?
So this has happened over, initially the patient was on 6-liter face mask when the initial ABG was taken. So this has happened around 3 or 4 hours, I guess.
Yeah. So
we don't have the exact timings.
It has to be that much because the bicarbonate change cannot occur so fast. If you look at the ABGs now, if you were to interpret the ABG, earlier it was 29. The bicarbonate, now it's 38. The PCO2 was 65, now it is double. Right? Yes. It has gone up by 65. And the bicarbonate has gone up by 9.
Around 9 or yes.
Yeah, so a rise of 1 for every 10 rise of PCO2 in the acute state, approximately. So that is what we're here. This is acute compensation of bicarbonate. 1 for every 10 of PCO2, right? It cannot happen so soon. It happens over a few hours, the acute change.
Yes.
And the acute compensation is never complete. That is why
it's never complete.
So that's just the interpretation of the ABG right in front of you. And the lactate has gone up. There is a significant rise in lactate. Why has the lactate gone up?
So again, sir, this could again be explained by the dynamic hyperinflation on the autopeep and the increased work of breathing. So that could lead to a decrease in RV filling and further compound the hypotension. And maybe that is leading to the lactate
rise. Hypotension is not occurring. Blood pressure is stable.
Sir, the other is the hypoperfusion of the respiratory muscles because they are working at a very high rate. So that could lead to a rise in lactate.
Yes. So the respiratory muscle activity, excessive respiratory muscle activity is leading to a rise in lactate. Apart from that, there are other reasons also in pulmonary patients who are in distress, especially asthmatic patients whose lactate rises. So Dr. Animesh sir, you would like to tell us about the lactate rise in pulmonary conditions, especially asthma and all, it has been described. I don't know whether it is true or not. They say even the pulmonary, the alveoli and the cells in the pulmonary parenchyma can produce lactate in states of distress, asthmatic conditions especially.
Oh, actually, I'm not aware of this. So probably you can throw some light on this.
So what that is why I'm just bringing up for discussion. So one of the reasons is the muscles are overactive. So the lactate is produced because, there is a relative oxygen deficiency. But what I've also read is that inherently, the parenchyma, the cells of the parenchyma also produce lactate, especially in asthmatics, it has been described. So that is what I just was trying to throw up. I'm not sure about this because that is more of a pulmonary thing. But definitely from a critical care point of view, when the muscles are over-exercised, there's a relative lack of oxygen and lactate goes up. So that is simple to explain. Okay, next one, please.
So invasive mechanical ventilation was then instituted in view of an IV failure, and again a size 8 of 82 was intended. And this was the ventilated settings that was set in the emergency department. A VCV and FiO2 of 100%, PEEP of 6, and respiratory of 28, and the IE ratio of 1:2.5. And the patient was subsequently shifted to the medicine ICU for further management. So again, a few indications of invasive mechanical ventilation.
Next slide.
So these are very predominantly the goals that are kept to be in mind. So we have to decrease the work of breathing and reduce the DHI. Avoid overdistension, keeping in mind the PEEP should be less than 30 centimeters of water. We have to ensure adequate ventilation as well as adequate oxygenation.
And also allow time for the primary process to reverse. That is very important.
Yes, sir.
It has to reverse. There's a pneumonia or there's an infection in the airways. Your antibiotics have to work. So whatever the primary process. Next.
Yes, thank you, sir. So on receiving in the C2 ICU, these were the vitals of the patient at the time of receive. So he was 150 per minute of heart rate and a respirator of around 41
Okay,
per
that's
minute.
fine. You don't have to read that. That is,
The patient was visibly
yeah, tell
distressed.
about what is going on the ventilator. Can you tell us what is going on the ventilator?
So the patient is, if you see the pressure scalars and the flow scalars, so we can see the expiratory, the patient is triggering another breath without the expiration of the previous breath being completed.
Okay. Kunal, I will explain. So you see this patient, if you look on the right side, there is evidence of air trapping. There is, the flow is not, the above one is pressure volume and the below one is flow volume. So you see in the pressure volume, the expiration is not complete. So this could mean there's an air leak or there is volume trap. So the things are possible. But if you look at the bottom one, that is a flow volume. The expiratory flow is not touching baseline. If there was a leak, it would touch baseline. So that means there is air trapping. And there is evidence of air trapping on the left side, bottom corner, you can see the flow scalar. So this is again not touching baseline. So there is clear evidence of air trapping, or what you call autopeep or dynamic hyperinflation. The other thing, which is very important, can you point out any asynchrony in this? In the pressure scalar, is there an asynchrony?
So there is a
cycling. Yes, there's a expiratory cycling asynchrony. What is, you can see the spike. Can you point out the spike?
It is spiking before the patient has time to cycle to.
Absolutely. So what has happened is you have set a rate of 0.6 Ti and Te 2.3. So that is a ratio of 1:4, right? But the respiratory rate is 41. So the rate is too high to allow a Te of 2.3. So that is what is happening. The patient's Te is not being allowed because it is not possible with a rate of 40. So the patient is expiring before inhalation is complete. By you getting a cycling asynchrony. That is what is happening here. Okay. So an inspiratory pause was done and it showed a high peep pressure with a high peep flat. And again, there was a end inspiratory breath hold was done and it showed a presence of intrinsic peep, which was around 6 and a total peep was around 12. So it confirmed the setting, it confirmed the suspicion of an autopeep physiology going on because of the dynamic hyperinflammation. So just one second, just go back. So, the normal difference, this is for the audience, is less than 5 between peak and peep flat. In conditions of airway disease, increases. And in conditions which is involving the parenchyma or the pleura, the peak and peep flat remain less than 5. So this is very important and it helps to differentiate when the pressure start going up, whether the process is in the airways or the process is in the parenchyma or pleura. The difference between peak and peep flat, normal being less than 5. Secondly, how long should the end expiratory pause be? So the end inspiratory pause is around 1 second, right? When we bring out peep flat. But the end expiratory pause, you like to give it longer, around 4 seconds, 5 seconds, something like that. And how does it help? How does the end expiratory pause help? When the patient is expiring, the pressure at the tubings or the valves, the inspiratory and expiratory valves, is not the same as what the autopeep is. So you have to bring out this difference. To bring out the difference, you give a pause. And when you give the pause, the system comes into equilibrium. The ventilator and the lungs come into an equilibrium. And not only the lungs and the ventilator, the different airways, the lung units are having different time constants. They're not homogeneous. It's not a homogeneous disease, COPD, when it goes into so different units, lung units have different time constants, different autopeeps. Some are open, some are partially closed, some are totally closed. So they also come into equilibrium. So lung units come into equilibrium and that is the lung comes into equilibrium with the ventilator. So the entire system comes into equilibrium and you are able to detect this actual intrinsic peak. That is the idea and the concept behind this. Okay, carry on.
So I'll just briefly discuss about autopeep in the COPD patient. So there are three mechanisms that have been described for autopeep. So in COPD, the classically what has been described is because of an intrinsic expiratory flow limitation, which I have described above. But also to remember, dynamic hyperinflation can also happen without an expiratory flow limitation component, as can be seen with incorrect ventilator settings or tube devices, or it can be happen without dynamic inflation even in asthma patients. So it leads to a progressive buildup of volume and leads to a pressure at the end of alveoli at the end of expiration, which leads to an autopeep. So how does it increase the work of breathing? So as the air is trapped inside the lungs at the end of expiration, so this exerts some amount of positive pressure, and to initiate the next amount of next cycle of breathing, the alveoli have to overcome with the pleura. They have to overcome this positive pressure further on to draw in that amount of air in the next cycle. What happens is in a lung,
Dr. Kunal, just go back to the slide. What is wrong with this slide, Dr. Kunal? Is there anything wrong here in this particular diagram?
Sir, cannot.
Okay, it is difficult for you to answer. So the thing is, you see, there is a pleural pressure also. There's something known as a pleural pressure, inherent pleural pressure. You see, at end expiration, in a normal lung, the lung has a tendency to collapse. Okay, so the pleural pressure is -5 centimeters, it pulls it outwards, otherwise it will collapse. The intra-alveolar or the pressure within the lungs is 0. Okay, now it is said that in emphysema, the entire PEEP is transmitted to the pleura. So if you have a transmission of 10 of your autopeep, your 10 minus 5, the pleural pressure will be 5, not 10. That is very important to understand, because ultimately when you apply PEEP extrinsically, all this matters. So they try to explain, they make all kinds of diagrams, but one has to understand the physiology. And one must realize there's a pleural pressure, inherent pleural pressure, and almost all the PEEP is transmitted to the pleura in patients of COPD. Now, this transmission of PEEP is very important to all the intensivists because there are so many conditions. So in a normal lung, half of the PEEP is transmitted to the pleura, because the pleural pressure is actually the intrathoracic pressure also. And in patients with ARDS, practically no pleural pressure, no PEEP is transmitted. So that is the way you go. In ARDS, hardly any PEEP is transmitted to the pleura. In a normal lung, half the pressure is transmitted, and in emphysema or COPD patients, the entire PEEP is transmitted. Next slide. So, Dr. AIIMS, sir, please, if you want to add anything at any point in time, please feel free.
Right. No, it's fine. Absolutely. Thank you.
Carry on.
So, in a patient who doesn't have any autopeep,
go to next slide.
So again, consequences of autopeep are the same as have been discussed in dynamic hyperinflammation and hemodynamic compromise, increasing work of breathing, worsening gas exchange, and further may also lead to inappropriate treatment and because of misjudgments in central venous pressure and incorrect fluid or vasopressor administration.
So hemodynamic compromise, just comment on the hemodynamic compromise. Please tell the hemodynamic.
Because of the increased intrathoracic pressure, because of the rising autopeep and dynamic hyperinflation, it can increase the pulmonary vascular resistance, leading to an increase in the RV afterload. So this leads to a decrease in the RV preload, can reduce the venous return, and so subsequently reduce the cardiac output as well, leading to a hemodynamic low perfusion state.
So one thing is very important as far as the heart is concerned, that a lot of these patients have cor pulmonale. They have right ventricular hypertrophy, yes, and sometimes there's a bulge of the IVS towards the LV, especially in acute deterioration where the pulmonary vascular resistance rises, this pulmonary hypertension worsening. So the RV further dilates and the IVS gets pushed into LV, limiting the filling of the LV diastole and cardiac output. So the cardiac output falls. So that's one of the things we see in these patients. And the other thing is that one has to be careful when one puts these patients on the ventilator positive pressure, because the blood pressure can crash. Because you're putting on positive pressure, already the lungs are hyperinflated, and there can be worsening in the blood pressure. One has to be very careful with that, and one should be aware of this. Okay. So the other, carry on, please, carry on.
So detecting autopeep, as sir has already discussed. So at the end of an expiratory hold, this baseline peep, the pressure scalar will not return to the baseline peep set. It will rise to a further amount of pressure, which will be nothing but the total peep. And the difference between total peep and the set peep will be your autopeep. The other thing which we can see in a flow scalar would be the incomplete returning of the expiratory limb towards the baseline, and the next breath being initiated before it returns to the baseline. On a flow volume loop, this is suggested by the fact that there is some amount of volume loss here, and this can be either because of air leak or air trapping, but this is this limb being lost in the expiration. Abrupt loss is suggestive of an air trapping physiology happening. So to troubleshoot autopeep, again, we have to look at ventilator settings, the patient factors, as well as do something for the flow resistance. So patient factors includes reducing the pain, the anxiety, and the fever, and the comfort of the patient with the help of sedation or some amount of analgesia. Apart from the ventilator setting, we can also try with the ancillary treatment for COPD, including the bronchodilators, suctioning when required, and using a large bore tube up front. Apart from this, the main troubleshooting for autopeep involves the ventilatory settings, which involves setting a higher expiratory time or a lower inspiratory time with the help of an I ratio, or setting a higher flow rate up till 60 to 80 liter per minute. Reducing the tidal volume and reducing the respiratory rate. Again, this tidal volume has to be titrated to around 6 to 8 ml per kg, and decreasing the respiratory rate is very important to prevent further autopeep from worsening. Trigger sensitivity should be sensitive enough to not miss the some of the ineffective efforts, but it should not be overly sensitive to lead into an auto trigger phenomena. Again, there is some amount of extrinsic peep concept that can be applied, which I'll discuss in the subsequent slides. So how does respiratory rate counteract the auto peep? So as we can see, there is a patient, who has a respiratory of 30 per minute, who has been set in I ratio of 1:2. Every breath cycle will be around 2 seconds, and an inspiratory time of around 0.7 seconds, and an expiration time of only around 0.1.3 seconds. Compared this to a patient who has a respiratory rate set at 10 per minute, again, at the same in the IE ratio, the patient will have a higher expiration time of around 4 seconds. That will allow more amount of air to be lost during expiration, and further decrease the amount of air trap that is at the end of expiration. So this is where the reduced respiratory rate comes into play. So discuss about the concept of applied extrinsic peep. So again, it's a little controversial, because as we have discussed, there is a heterogeneous distribution of expiratory flow limitation and air trapping inside COPD lungs. So the positive points towards it is it prevents atelectotrauma, and PEEP also reduces the work of breathing by decreasing expiratory lung volume. But the negative point could be that it can potentially worsen dynamic hyperinflation and autopeep as well. And further leading on to a vicious cycle of ventilator-induced lung injury, asynchrony, prolonged weaning. So the strategy that is suggested is to set PEEP at around 80% of the intrinsic PEEP, which is calculated, and titrate up to a point where there is no further rise of peak plateau or the peak plateau pressures. The role of applied extrinsic PEEP is mostly described as beneficial in patients who have a component of expiratory flow limitation, as in COPD. And also, again, it is not been found very helpful in patients with asthma or components where there is no expiratory flow limitation. So how it works is that the lung already has a auto PEEP of, let's say, 10. And the ventilator is not giving, we are not giving any PEEP. So the patient has to, and there's a triggered sensitivity of -1 liter per minute. So the patient, -1 centimeter of water. And the patient has to pull in, take a pressure drop of around 10 minus -1 of around 11 centimeter of water to pull a breath in. Compared to this, when we apply PEEP, let's say we apply a PEEP of around 8 and the patient has an auto PEEP of 10. So now the patient has to only take in around a negative breath, a pressure of 10 minus 8 minus -1. So around a difference of only -3. So this leads to a significantly reduced work of breathing and further reduced asynchrony in the long run. So the other way this works is when you apply a higher PEEP, it stents open the airways. As we know, the sir has rightly pointed out in the beginning, there's a component of airway resistance and because of the mucus hyperinflammation or hypersecretion. So there is some component of airway resistance, and as well in the smaller airways as well in the larger airways. So when we apply PEEP, it sprints open the airways so that more amount of air that is trapped in can be released subsequently. So how do we do this? We apply PEEP, titrate PEEP by 1 centimeter of water stepwise, while keeping in check the PEEP plat as well as the total PEEP. And we increase PEEP till there are no missed triggers, and we stop at a point where there is any further rise in P flat or P peak, which because that will imply worsening hyperinflation and worsening air trapping. So this is the fine point of balance where we have to titrate the extrinsic PEEP in a patient with COPD. So again, to remember, this concept of applied extrinsic PEEP is only useful in patients who have a component of expiratory flow limitation, as in COPD. It may not be useful in patients who have asthma or other non-expiratory flow limitation component.
So here, you like to explain why it is not helpful in asthma, or Dr. Animesh or anybody would like to explain why PEEP is not useful in asthma? Okay, we'll come back to this. Carry on.
Coming back to a patient, so we detected this to be autopeep. Bronchodilators were given, and the settings were changed back to a respiratory rate of 18, and I ratio 1:4.5.
Just go back to the slide. Just go back on your slides.
So this one.
Yeah. Okay. So now, just to put it simply, how does extrinsic PEEP help? So one must realize that there are airways which are collapsed. Okay, there's a collapse in this airway, and these collapsed airways are opened up when you apply extrinsic PEEP. What is called stenting of these airways. Okay, and that is the difference from asthma. In asthma, there is no collapse of the airways. If you remember what I said in the beginning, because of the loss of elastin fibers, there's a tendency for the airways to collapse. And these collapsed airways are opened up by giving extrinsic PEEP. Okay, that does not happen in asthma. In asthma, there is only narrowing. There is a diffuse narrowing, intense bronchospasm. The PEEP is not going to help. PEEP helps by opening up these collapsed airways by stenting them. So there is easy egress of expiratory volume. And second is, because there is an autopeep, it actually homogenizes the difference, the gradient from the lungs to the tubings, to the valves, inspiratory and expiratory valves. So you are able to generate the inspiratory volume in an easier manner without exerting too much effort, like he told you. He showed you that diagram where there was -1 trigger and -3 trigger. Yeah, this one. So I think this was very clear. He has explained very nicely. So these are the two ways in which extrinsic PEEP actually helps. And
yeah, if I would like to add one point,
yeah,
after you, please.
Yeah. So the other thing is, if you have to set 80% of the measured PEEP, and the measured PEEP on the invasive ventilation, you have to give an autopeep. Patient should be, sorry, you have to give a expiratory hold. Patient should be paralyzed, and you measure the intrinsic PEEP and give 80% of that maximum. This concept of giving extrinsic PEEP is overhyped. I've seen patients setting an extrinsic PEEP of 8 on NIV without measuring anything. It is a very common mistake, actually. Even if you read the literature and if you work, amongst the junior colleagues, it is very common to feel this hype of giving extrinsic PEEP in COPD. Even if you do not know how to measure or do not know any method, do not give an extrinsic PEEP of more than 5. That is enough. The extrinsic PEEP is not more than 10 in most of the circumstances. It is 6, 7, 5 variable. And all patients who go into invasive ventilation have some degree of dynamic hyperinflation. There is autopeep if they go on to the ventilator. Most of them with severe acidosis on NIV will also have some degree of dynamic hyperinflation or autopeep. That is very important to realize. Now, coming to the other factor, there is an element of even worsening if you give too much of an extrinsic PEEP, because this will transmit to the lungs and actually lead to increased volumes and increased plateau pressures and peak pressures, leading to barotrauma. So this is what you to say. Dr. Animesh sir wants to add something.
Right. No, the point which I would like to make was that, this extrinsic PEEP is again required when the patient is on, say, a assist control mode or a pressure support ventilation. So that when the patient is triggering the ventilator, when the patient is, on mandatory ventilation, then extrinsic PEEP does not actually, it does not have much of a bearing, because in that case, helping the patient triggering is out of the question because the patient is, is on mandatory ventilation. So that happens typically when the patient is sedated and paralyzed. Now, talking about ventilating patients of asthma, one difference, there are several differences between ventilating patients of asthma and COPD. Now, in asthmatic patients who land on mechanical ventilation, and that's a rarity, I won't say that's a rarity, but that's that's tricky because these patients, they are, they have a different pathophysiology altogether. And a lot of times ventilating these patients, they're very difficult on, on assist control mode. So a lot of these patients, they are sedated paralyzed, and we typically, aim for very low respiratory rate, say respiratory rate of say 6 to 8, so that, the prolonged expiration is allowed, that is done. So most of these asthmatic patients who are mechanically ventilated, they end up getting sedated and paralyzed. So that is also one of the reasons why, we don't think about applying extrinsic PEEP to asthmatic patient.
Okay, great. Carry on, Dr. Kunal.
So after making these appropriate settings, we noticed a comparative resolution of PPIC and PPLAT and somewhat comfortable looking patient, and better graphs and scalars. And although there was still a component of airway obstruction.
So just go back. So now, Dr. Kunal, in the flow volume loop, right, on the bottom side there, yeah. Is there anything which is characteristic of COPD?
So the scooping in the expiratory lane is.
So this is called scooping. Can you explain it to the audience? What is this?
So initially they will, when they try to expire, they'll be very high. They can generate pressures, but over time, as there is a Bernoulli's effect in play, so those small airway will collapse and leading to leading towards resistance in the air being expired out. So there will be a period of resistance here, because of which there will be prolonged expiratory phase after initial period of
yes, so this particular thing which is occurring in the expiration, which is just pointed out, this is called scooping, and it is characteristic of COPD patients. It can also be seen if the tube is of a small size, or there is mucus obstruction, any kind of obstruction occurring. You can see this, and this is called scooping. It's difficult to explain what the normal expiratory flow is. One should know it. You can look it up, but this is characteristic of COPD obstruction. Next.
Sometimes there is a life-threatening autopeep in the form of imminent cardiovascular collapse and hypotension and very high airway pressures, and the patient being in significant distress. So, and these times it is also recommended that we can immediately disconnect the patient from the ventilator, the intratracheal tube from the ventilator, and this allows the air which is trapped inside to let it out and let the autopeep come back to a normal intrinsic baseline peep. So this is one of the effective and life-saving measures for testing as well as abolishing autopeep in patients who have a life-threatening cardiovascular complication leading to this. So again, summarizing the initial settings, or I would say these will not be the ideal settings, but these were the initial settings in any patient with a chronic obstructive pulmonary disease presenting with acute exacerbation. So I would like to keep again a ventilate volume control mode over a pressure control mode, a low tidal volume, a low respiratory rate, a longer expiration time with a shorter inspiratory time, or if allowed on the ventilator, a higher flow rate of around northwards of 60 liters per minute, flow trigger sensitivity around 2 liters per minute, and an extrinsic PEEP again in very particular circumstances around 80 to 85% of intrinsic PEEP. Again, that has to be very carefully titrated, and an FiO2 to target an SpO2 of around 88 to 92%. So coming to the modes of mechanical ventilation, so again, we prefer volume control mode, and the reasons being, in a pressure control mode, we cannot control volume. So there is a very high chance the patient may be underventilated and might land up into hyperventilation and further worsening of acidosis. Also, because of the high upper airway resistance. So volume control mode is what is preferred over pressure control mode. And also volume control maintains minute ventilation, so that also there is a high risk of air trapping, but there is not a risk of further worsening of hyperventilation. Although there is no any robust evidence or a head-to-head trial to support either of those modes. So another alarm goes off on day 3 of ICU. So this patient is now having a sympathetic response in terms of high tachycardia, tachypnea, and high blood pressure. and there are thick coarse crepitations and thick secretions in AT tube noted. So again, this time an inspiratory hold was done and a peak pressure was found to be very high. On the examination, there was no V's. So
what has happened here? The peak pressure has gone up or what?
So the peak pressure has gone up while the P plat has remained more or less the same. So then the difference between the two.
Can this be embolism? Can this be pulmonary embolism? They are prone to pulmonary embolism.
Sir, this pulmonary embolism little less likely, sir, because this can be more or less explained by either the patient has gone into a bronchospasm or because of the other features suggesting there might be secretions pulled up.
Fair enough. There can be bronchospasm. There can be thick secretions. Why is it not pulmonary embolism? His saturation has dropped.
The saturation has dropped marginally, and it could be pulmonary embolism. But again, the blood pressure has not dropped to that extent.
Anything on your ventilator data which tells you this is not pulmonary embolism? What happens to your ventilator data when there is pulmonary embolism? It does not change.
So it usually does not should not change. So
it is a vascular phenomenon.
It's a vascular thing, unless
okay. So that's very important. You know, we often suspect pulmonary embolism occurring on the ventilator. Patient desaturates. Sometimes it's hypotension. So whatever settings you have in terms of peak and P plat will not change. Very rarely you can get some degree of bronchospasm that occurs because of release of serotonin and other vasoconstricting substances by the pulmonary embolism. That's very rare. So initially, you know, when you're looking at the patient in the ICU, suddenly there's an event, and you know we often suspect pulmonary embolism. That is one of the ways to make out. The ventilator data in terms of P plat, etc., will not change. Carry on.
So again, nucleotics were added, suction was done, and the status again came back to the normal state, and the weaning was continued. Again, this is about the monitoring. This we have discussed. We try to keep a peak will usually be high in these patients because of the airway resistance, and P plat we try to target to a normal less than 30, and this is how we also monitor some amount of autopeep as well as a dynamic hyperinflation. Blood gases, we try not to target a perfect ABG or try not to target even a normal PCO2 in these patients. We try to achieve a baseline PCO2, which again in this patient we could not find out, but we were assuming this should be usually around higher side, about 50 to 60.
It's very important to realize that when you ventilate your aim is not to correct the gases. You maintain, you have to decrease the inflation, the dynamic hyperinflation. That's very important.
Yes, sir.
Carry on.
So a concept of permissive hypercapnia has been suggested, and so that we allow CO2 to rise up till, let's say, 90, or pH to go up till 7.25. Sometimes in literature it has also been reported to even 7.2 before we take corrective steps. And the goal is to allow the rate of allow CO2 to be lost, but at a slower rate, so that this prevents a rebound alkalosis, which is seen in post CO2 washout hypercapnic alkalosis, or avoid sudden electrolyte imbalance in the form of hypokalemia.
What is rebound alkalosis? Can you explain what is rebound alkalosis?
So in a patient with
also known as post-hypercapnic alkalosis or overshoot alkalosis. What is this?
So in a patient with COPD or an obstructive physiology, there will be in a persistent state of chronic respiratory acidosis compensated. So bicarb will be on a higher side. So if we ventilate them too aggressively, or we try to wash off the CO2 too aggressively, they will go into a metabolic alkalosis because the kidneys won't have time to compensate for that amount of rise bicarb. So when they go into when the CO2 goes,
so the bicarb remains high, the CO2 goes up to normal or below normal. If you overventilate them, so you get a metabolic alkalosis. Yes. And this metabolic alkalosis can be detrimental. It can throw the patient into seizures also, cardiac arrhythmia. So sometimes there's overzealous correction. So one has to be very careful about this. Coming to the other thing. So you have mentioned pH should be more than or equal to 7.2 in permissive hypercapnia. And the PCO2 90 to 100, I'm not so sure. Is this given everywhere, or where did you get this? Because PCO2 is not really the criteria. It's the pH, because the PCO2 is a little variable depending on the compensation and what state you have. Now, Dr. Meena sir, you'd like to tell us the physiological effects of hypercapnia. Dr. Meena sir. Are you there, Dr. Meena? You're muted, I think. Okay, so I don't know. So the physiological effects of Hypercapnia or what? One, it leads to pulmonary hypertension. It leads to increased cerebral blood flow due to vasodilatation. Then it leads to sympathetic activity, which increases myocardial contraction, increases the heart rate. And on the systemic vasculature, it leads to vasodilatation. So there's an increase in cardiac output, but there's a vasodilatation, so the blood pressure remains normal. So these are the physiological effects of hypercapnia, which is not so uncommon at all in the ICU, especially in ARDS patients, where they stay for a longer time and the PCO2 goes up. Here, they stay for a shorter time, so the effect is not that important. Definitely in ARDS patients, the hypercapnia, his physiological effects become very important. Anything you want to add, Dr. Nimesh, sir?
No, the one thing is, I mean, as you rightly said, that we are not very concerned about the PCO2. The PCO2 may be it may be even, for as much as I care, it can be, above 100 also, provided, we have an acceptable pH and the patient, the rest of the respiratory parameters, the respiratory rate, the peak plateau pressure, they are fine. So we should not be targeting the PCO2. We should rather be targeting, the overall respiratory pathophysiology, and we should be also monitoring the pH. pH less than 7.2, that may be a problem because as you said that it might have inadvertent effects on the cardiovascular system. It might cause hypotension, etc.
Yeah, and the other thing is like yes, at the bottom, avoid in intracranial disease. So CO2 levels you have to watch in intracranial disease because they lead to raised ICT because of vasodilatation, and because it can cause pulmonary vasoconstriction, you have to be careful in core pulmonary conditions. So there you have to monitor these situations. One question to you, Dr. Kunal. You have this neuropsychiatric effects of hypercapnia. Okay, and when the pH is altered or the PCO2 is altered, the effect is generally seen, right? You have a pH or acidotic and PCO2 70, 80, maybe 100. Sometimes the pH is not too altered, there's compensation. Sometimes it is very altered, there's not much compensation. So the neuropsychiatric effects are because of CO2 levels or because of the acidotic pH? Dr. Kunal.
I think it's because of the CO2 leading to vasodilation in the cerebral vasculature, leading to a increased perfusion there. And
it is
also,
not due to,
it's also
the first part of your answer is right. It is due to CO2. It is not due to the pH. That is why it is also called CO2 narcosis. Just term it loosely. But the real reason for CO2 narcosis or neuropsychiatric effects of hypercapnia are not known. Probably it is mediated through neurotransmitters. It is not known. So you look up the literature. This is very interesting. What caused the neuropsychiatric effects? It's so common. Hypercapnia patients getting obtunded, drowsy, or sometimes getting agitated. What causes this? It is not the increased flow. It is an imbalance in chemicals, neurotransmitters. It is not known. Okay.
I'll look it up, sir.
Anything you want to add, Dr. Nimesh, sir?
No, I mean, I absolutely agree with you, but also added to the fact that these patients in the ICU, they also receive other agents like steroids, which are known to have some, effects on the neuropsychiatric milieu, as well as they are in the ICU delirium. So, multiple factors act on these patients in the ICU. And so a lot of these patients, they end up having more delirium or more, neuropsychiatric manifestation as compared to the other patients.
Right. Okay. Thank you. Carry on.
Let's not forget the ancillary therapy and treating the underlying disease, which includes again bronchodilators, which can be delivered either via MDI or nebulization, glucocorticoids in a severely in an exacerbation patient, antibiotics when there is an evidence of underlying pneumonia, sedation, paralysis. Usually we try only with an analgesic sedation approach and with propofol or ketamine, and sometimes with dexmedetomidine, which we have been recently started to use, especially during the weaning phases. And usually avoid neuroparalytics or even benzodiazepines for these patients or for any critical illness patients.
How long should you give steroids? I mean, in these patients, when the patient, do we taper them once he gets well, or we do not need to taper them? Like, what is the recommendation for steroids?
So traditionally, 5 to 14 days. I mean, there's a long range which has been, tried in COPD patients. But as of now, recent data, there was a trial recently called the reduced trial, which which compared between 5 and 14 days. And they showed that 5 is as good as 14 days, as far as, decreasing ICU shift is concerned. I mean, shift from ICU to other.
So we can stop it as soon as he gets well. There's no need to continue
Yes.
to.
I mean, minimum 5 days is good enough. Minimum 5 days.
Okay. Then another thing is, about this steroids. Sometimes patients have peptic ulcer disease or certain contraindication to steroids. So I read somewhere, high dose budesonide to the tune of 2 grams QID can be given. So is this okay? I mean, you being an expert on this.
No, I mean, absolutely. So, I mean, there has been some trials between inhaled corticosteroids vis-a-vis systemic corticosteroids. So higher dose, in fact, they have used as much as 4 to 8 grams. I mean, one Budecort respules have 0.5 gram. So 4 gram would be, 8 respules per day they have used.
Yeah, that's what 4 grams per day. 2 grams QID is what I read, 1.5 to 2 grams QID. So this happens sometimes. You can't use steroids. So that's a message that you can use high dose steroids, 2 gram QID or something like that in these patients. So that is. Have you used this ever? Have you actually used it?
No, I mean, we generally have not. I mean, we generally do it with systemic steroids. We have not particularly encountered where we cannot use systemic corticosteroids. But one comment I wanted to make, and we have discussed this many times with Kunal and other of our colleagues there, that a lot of time what we do is give both inhaled steroids as well as systemic steroids. I think that is not warranted. No data, no study as such show that we should be using both. So if possible, use systemic steroids. If not, then aim for high dose inhaled corticosteroids. But giving both, I don't think it makes any sense.
I think that's a very, very important point. This is a very rampant practice. Even in work, people give both steroids, IV and nebulized. So this is a very important take-home message. There is no recommendation like this at all. So one should unnecessarily, you cause complications by giving too much steroids then. And about this, sedation with propofol or ketamine. So no, the only reservation I have about ketamine is that these patients have one neuropsychiatric symptom sometimes. And the other thing is ketamine is known to increase secretions, airway secretions. So that sometimes cause a problem. But propofol is very nice. It causes bronchodilation. Ketamine also causes bronchodilation. That is why it's probably recommended. But the other side of the coin with ketamine is it increases bronchial secretions. But propofol does not have this property, and propofol also causes bronchodilation. So we are more comfortable with propofol. So that's just a point I wanted to make about sedation and anesthesia. Carry on.
Thank you for putting forward this point, sir. So day 4 of ICU stay, and the patient is now on a pressure support ventilation of 10/5 and 30% is maintaining. And he's having a normal to slightly lower side pH of 7.38. Meanwhile, his labs have over the trend have shown an improvement in the terms of leukocytosis as well as
so don't need to read. No, don't read. Don't takes too much time.
Overall, there was an
the thing is now that the TLC is increased because there was a pneumonia, right? Okay.
Possibly, yes, sir. Yes.
Is increased. The urea to creatinine ratio is more than 40, which indicates prerenal azotemia. Probably either there was a worsening of the cardiac output or he was dehydrated. Then you come down to procal. Procal is again high. That is again because of your pneumonia. So that is the interpretation here of the labs that you have. Next slide.
So at day 4, he was clinically stable.
Okay,
labs
so
were
Dr.
improving.
Animesh sir, in this X-ray in the left paracardiac region, is there some lucency? I mean, are there bullae or pneumothorax? Any suspicion like that? The lucent area, yeah, here.
Yeah, this one. I mean, I can see some, lung markings beyond that. So I would not say that they are probably pneumothorax, but it definitely arouses the suspicion of some amount of, hyperinflation or, some cystic changes in the lung, probably compatible with emphysema.
Right. Next slide.
So he was extubated to NIV subsequently and shifted out to ward. So then extubation in COPD, again, some few points. again, evidence is very strongly in favor of NIV for mitigating reintubation as well as to facilitate weaning in patients with COPD. Even if there has been a failed STB, you can extubate the patient to an NIV. And if there is a, after extubation, if the patient is going towards a, looking like the patient is going towards a reintubation or a failed extubation, then rescue NIV can also be applied. Then some
just
upcoming...
go back, just go back there. So Kunal, one thing I would like to point out here is that if you have a failed SPT, all patients cannot be extubated to NIV. It depends on the degree of failure, how bad the patient is failing on the SPT. If the patient is getting grossly hypercapnic or tachycardic, blood pressure is dropping drastically or jumping up, or the patient starts sweating, you cannot extubate him. That is why some of the patients go on to tracheostomy and have a prolonged stay. So if there's a marginal failure, yes, you extubate them and they will come out. Or you want to try, there are problems, you can't keep him on the ventilator. But patients who fail SPT badly cannot be extubated. That is a strong message I want to send, because this is again a misconception that you put all patients once they're in 48 hours, you give them ventilation, bronchodilators, antibiotics for 48 hours. As soon as there's some improvement, extubate them to NIV. That is wrong. The SPT has to be given. The SPT, if it fails significantly, you cannot extubate them. And you have to again assess them, again give them a SPT. And some of these patients will go on to tracheostomy. And they go on to tracheostomy, and with the tracheostomy, some of them stay on for weeks and months also. I mean, that may not happen in our centers, maybe, because of financial considerations in the corporate hospitals. I don't know how it is with you, or the care is not so good later on and they succumb. But definitely in the Western literature, a lot of them go on to tracheostomy and they have a prolonged stay and so on and so forth. They come out after 1 month, 2 months also. So this should be very clear. The next slide. Anything, Dr. Ramesh sir, you want to add to that?
No, absolutely. Yeah, I fully agree.
Next slide.
So the role of high flow nasal oxygen in COPD patients. So again, it has been considered as an alternative to NIV, especially in
here,
Kunal,
the problem is high flow nasal oxygen has not been approved. Whatever trials have been done have not shown it superior to NIV. The reason for that is, can you tell me simply in one line what is the reason why high flow will not work in COPD?
Sir, it will increase the oxygen flow and further question.
No, that you titrate. It will not help because unlike ARDS, in COPD,
no shunting.
Fatigue. And respiratory fatigue is alleviated by giving pressure support. And you do not give pressure support in high flow nasal cannula. In ARDS patients, there is no respiratory fatigue most of the time. Some of them, yes, do have. But most of the patients come with a high respiratory drive, high tidal volumes, high respiratory rate. What happens to minute volume in patient of COPD? It is low. Tidal volume is low, respiratory rate is high. But the minute volume and tidal volume is actually low. In ARDS patients, the other way around. They generate tidal volumes of 12 ml, 13 ml per kg. So they come with respiratory fatigue. That is why it will not work, because you need pressure support to counter respiratory fatigue. I mean, you can try it because there are some finer points. The alveolar ventilation increases, the washout increases, but trials have not shown, and I don't think they will show.
That is true, sir. There are not recommendations per se.
No, I agree. What you have shown is perfectly fine. I'm only giving the reasons. There is no
yes,
to use it as a primary therapy. When you're
exactly.
you can use it. Your slide is perfectly fine.
Yes, sir.
Carry on, next slide.
So again, still data is still lacking. It may be just considered as an alternative or as a supportive adjunct to NIV in weaning off, or in patients who are not having a full-blown respiratory acidosis. Their hfnc can be considered if there is sole hypoxemia. So some amount of hfnc can be helpful. Then role of acetazolamide as a stimulant has been also tried in a few studies. So the concept being behind it inhibits the carbonic anhydrates, increasing the bicarbonate loss through the kidneys and inducing a state of metabolic acidosis, which increases the respiratory drive and leads on to a successful weaning and extubation for the patient. But the double-edged sword in COPD being that in mild to moderate patients, they can mount a ventilator response if the muscles are not so offloaded and the muscles are not in so much fatigue. They can clear off the CO2, which is which happens because of the acetazolamide. But in severe COPD,
Kunal, actually, acetazolamide is not really used anymore. This is an old drug in terms of stimulation. What is the role of acetazolamide in COPD patients, the practical role?
So in post weaning, there can be some states where there is metabolic alkalosis. So to wean off those patients, we after correcting all causes of alkalosis, we can give acetazolamide to correct that metabolic alkalosis.
Absolutely. The role of acetazolamide is to correct metabolic alkalosis because it becomes difficult. Sometimes you get Lasix, steroids, because Lasix for core pulmonary, steroids you give them, and there's a fall in PCO2, so there's a uncorrected bicarb component. So metabolic alkalosis becomes a problem. The bicarb goes to 40, 45 sometimes, and it becomes difficult. Okay. The other question is, if we have a post-hypercapnic alkalosis, right? Metabolic alkalosis. Metabolic alkalosis is classified as saline responsive and saline non-responsive.
Non-responsive.
Post-hypercapnic alkalosis, if it's not getting corrected, will it respond to saline or not? Is it saline responsive or saline non-responsive?
It will be saline responsive, sir.
Very good. Sure. This post-hypercapnic alkalosis, metabolic alkalosis is saline responsive. That is because the elevated PCO2, the hypercapnia that occurs, alters the physiology in the renal tubules. That is why it is saline responsive. Okay, next slide.
Just to summarize this as the end, I'll just go into the take-home messages. So NIV is the first-line modality in any acute exacerbation COPD and the standard of care. So titrating, monitoring, and detecting failure of NIV is crucial, and to decide when to initiate invasive mechanical ventilation if needed. Then the goals and initial settings of invasive mechanical ventilation should be very clear to decrease the amount of dynamic hyperinflation, because that will then ultimately decrease the autopeep and the subsequent work of breathing and lead to a better, faster resolution and early weaning of the patient. Role of supplemental oxygen I have discussed, just to avoid hypoxemia as well as to avoid induced hypercapnia. It has to be titrated very carefully to target a saturation of 88 to 92. Role of applied PEEP, again very controversial. It has to be done in a careful supervised setting. Then again, we try not to target a normal blood gas, but we try to target a normal pH and then normalizing PCO2. Then hfnc role is still yet to be emerging and yet to be decided in COPD patient with exacerbation. So would you like to add on any?
Yeah, so this is the last slide. Okay. So,
yes,
so Dr. Kunal, one thing we did not discuss, one very basic thing, why is there hypoxia and hypercapnia in COPD patients?
So hypoxia is because of the dead space, sir. Increased dead space because of the loss of the alveoli walls and the elastic restraints. So there is a dead space, and because of that, there is a hypoxia. Hypercarbia can be explained by the fact of dynamic hyperinflation and the air trapping because of the expiratory flow limitation.
How does that cause hypercapnia?
Subsequent cycles of breath will lead to poor expiration and increased expiration, leading to the CO2 not being cleared up with subsequent cycles. And so,
so you mean the volume, the time volume is less?
End volume will be high, sir. End volume will keep stacking up.
No. If tidal volume is high, then we should clear whatever the dynamic hyperinflation.
But because of the resistance, it is not clearing up, sir.
Huh?
Because of the resistance and the expiratory flow limitation and the airway collapse, it is not able to completely expire. So there is amount of air.
What happens is the V by Q mismatch is prevalent for both hypoxia and hypercapnia, right? V by Q mismatch leads to both hypoxia and hypercapnia. When there is a hypercapnia, the minute ventilation increases generally to clear off the carbon dioxide in any patient, any physiology. The minute ventilation is increased or normal in patients of stable COPD, right? But it is not sufficient to clear the hypercapnia. It is inadequate, the alveolar ventilation. Though it is increased more than normal or maybe normal, it is not sufficient to clear the hypercapnia, which is caused by V by Q mismatch. That is the cause of hypercapnia in stable COPD patients. The tidal volume is even high in these patients despite dynamic hyperinflation. And all patients do not have dynamic hyperinflation who have stable COPD. When the patient gets admitted, right, his respiratory rate goes up even further and tidal volume is low. So there is further worsening. Because respiratory rate goes up, expiratory time goes down, and tidal volume is actually decreased in these patients when they get admitted. So that, in a nutshell, is the cause for hypercapnia. So very important to understand the physiology also of these patients. And my message is only one: do not give external PEEP of more than 5 in any patient of COPD. It is overhyped. That's all I wanted to say. Now request Dr. Animesh sir to close it with this final comment.
No, I mean, so I think the Kunal has already highlighted the important point. So in as far as acute exacerbation of COPD patients are concerned, I mean, there are 3-4 aspects that we usually concentrate on. And he based his presentation on this. One is obviously the general COPD management, that is bronchodilators, steroids. The second is management with NIV. And the third is via invasive mechanical ventilation. So management of all the 3 aspects, they are different from each other. And as one moves from one to the other, I mean, from NIV to IV, then the chances of adverse prognosis, it increases. So, but then again, these are very important patients. These are patients in which the outcome can be very promising if we get our basics right. So for management of acute exacerbation of COPD who are mechanically ventilated, the primary concept that we should be targeting is the dynamic hyperinflation, and as an offshoot of that, autopeep and so on. So if we get our physiology right and our ideas about the pathophysiology right, I think we would be able to manage this dynamic hyperinflation. So that is all I want to say. I would like to thank Kunal, who really put in a lot of effort in this presentation, and I would also like to thank Dr. Tapesh for giving us this opportunity and for having this lovely discussion. So it's a Sunday afternoon, but over 2 hours I really enjoyed it. We had a very wholesome discussion where I also ended up learning a few points, and I made some notes, and I'm going to look up certain points which have been brought up and about which my ideas have not been very clear.
So thank you, Animesh sir, first of all to you, because you really moderated excellently, and so nice of you to get this going, because after all AIIMS is AIIMS, and it is my alma mater. I know what goes on there, and there can be nothing better than presentations from AIIMS, and that is what Kunal has done, typically of a AIIMS senior resident presentation in keeping with All India Institute of Medical Sciences. Thank you, Kunal. That is a lot of hard work there. I can make out very nice slides and all the references there, and everything factually very correct. Thank you so much, Dr. Kunal. All the best for your future and your United States journey. All the best. Thank you, Animesh. Thank you very much. I think has gone. Thank you very much.
Thank you. Thank you.